2010. And since 2016, we've been publishing provincial level estimates from the Tenbison model. Previously, it was only national estimates. Since 2017, Tenbison has been the official model used in producing the UNAIDS estimates for South Africa. And the version of the model that I'm going to be presenting today is version 4.4, which hasn't yet been released, but it should hopefully be released in the next week or so. This new version of the model has incorporated a number of new data sources and a number of methodological refinements. And I'm really sorry about the slides. It seems we are having a technical issue here. I think we might need to switch to using your version, Nisha, if you don't mind.
No problem.
I'm going to stop sharing.
If you can just indicate when you can see the
Sure.
slides.
Yeah, I can see your slides.
Okay, there we go.
Great. Okay, so next slide. Okay, we've already been through this, so next slide. So just to give you an overview of what I'll be covering in this presentation, I'll give you a quick overview of the Tenbison model for those of you not familiar with the model. I'll then present the key results for the Western Cape. I'll talk a little bit about why the new version produces different estimates compared to previous versions. I'll then look at how the Western Cape compares with the other provinces, and then I'll finish off with some discussion on how we plan to improve the Tenbison model in future. Next slide. So Tenbison is what we call a compartmental model, which means that the population is divided into a large number of compartments, and within each compartment, we're assuming everyone is homogeneous. These compartments are defined in terms of a number of variables. Firstly, we have demographic variables like age and sex. We have sexual behavior variables like sexual experience, marital status, commercial sex activity, sexual preference. We also stratify the population by access to HIV prevention services. So here we're referring to things like HIV testing history, receipt of PrEP, and male circumcision status. And then finally, the HIV positive population is further stratified into a number of different HIV disease states. Next slide. And this slide is showing how those HIV disease states are defined in adults. The different rows here represent different levels of immune suppression, and the different columns represent different levels of engagement in HIV care. So the first column is representing people who've never been tested for HIV. The second column is people who've been tested but not diagnosed. The third column is people who've been diagnosed but not yet started ART. And then the final set of columns is representing people who've initiated ART, further stratified according to their baseline CD4 count and time since treatment initiation. And the different shades of red here just represent different levels of mortality risk. Next slide. When we talk about calibration, we are talking about the process of making sure that the model outputs are consistent with real world data. And there are a number of different data sources that we use in calibration, which are listed here. It's important to note that the calibration process is different in the national version of the model and in the provincial versions of the model. So in the last two columns, I've indicated which data sources are used in each. You'll see that there are several data sources that get used in calibrating the national model, but not in the provincial model. In some cases, just because the data are too sparse at a provincial level. In other cases, we just don't have the data disaggregated at provincial level. Next slide. The slide is showing the model calibration to the HIV prevalence data in pregnant women in the Western Cape. The first panel is for women of all ages, all pregnant women, that is. And the other panels are showing the results for each age group. The dots represent the data from the antenatal clinic surveys, and the solid line represents the average of the model estimates. And you can see that in all the age groups, the model results are fairly consistent with the antenatal survey data. Next slide. Here we're looking at the model calibration to the HIV prevalence data from the household surveys in the Western Cape. And here we see that the model doesn't provide a very good fit to the data. So in the period up to 2012, the model is consistently higher than the survey estimates suggest. But in the period after 2012, the model estimates are lower than the survey results. And this has been the major headache in terms of calibrating the Tenbison model for the Western Cape. The household surveys and the antenatal surveys are essentially telling different stories about HIV prevalence trends, and it's very difficult to get the model to match both data sources. We end up with a calibration that is quite good for the antenatal survey data just because there is more antenatal survey data, but the calibration to the household survey data is not very good, and this has always been a concern. Next slide. We also have household survey data on treatment coverage. In the two most recent HSRC surveys, they did antiretroviral metabolite testing. And this slide is showing how the model results compare against the survey data. You can see that there's a reasonable degree of consistency. Next slide. We also have reasonable consistency with the Western Cape program data on total patients on ART. Next slide. And we've also had good consistency with the proportion of adult patients who are male. Next slide. In the most recent round of the model updates, we've also been calibrating to recorded death data. And so in this slide, we're looking at deaths due to all causes in the 20 to 59 age range. In other words, the age range in which we would expect most of the AIDS deaths to occur. The red is for females and the blue is for males. You can see that in women, we get a fairly good fit to the data. But in men, we seem to be slightly underestimating the numbers of recorded deaths. And we think that this might actually be a problem with our non-HIV mortality assumptions, which we need to go back to. Next slide. Here we're looking at the model estimates of trends in new HIV infections and AIDS deaths. The dashed lines here, by the way, are the 95% confidence intervals around the model estimates. So the blue line is showing that the trend in new HIV infections, which peaked around 2003, about 4 years later than the national peak. And since 2003, there's been a slow but steady decline in annual new infections. The red line is showing you the trend in AIDS mortality, which peaked around 2004. And the model is suggesting that although there was a significant drop initially following the rollout of ART in the public sector, levels of AIDS mortality have been fairly stable since about 2008 in the Western Cape. Next slide. The next slide is showing you how the treatment cascade in the Western Cape has evolved over time. So the different colors are corresponding to different levels of engagement in HIV care. Green is representing people living with HIV who are undiagnosed. Yellow is people who've been diagnosed but never started treatment. The light orange is people who were previously on treatment but not currently treated. The dark orange is people who are treated but not virally suppressed. And the dark red is people who are virally suppressed at a threshold of less than 1,000 RNA copies per mole. Next slide. Vanessa just asked me to show you the most recent results in a little bit more detail. So these are the results for 2019 and 2020. You can see that we've made a lot of progress in terms of getting people onto treatment and getting people diagnosed. But a lot of the diagnosed individuals are not yet on treatment. And you can see that in these two most recent years, a significant fraction of those diagnosed untreated individuals are people who were previously treated but not currently on treatment. Next slide. A lot has changed to the Tenbison model over the last 2 years. I was actually asked 2 years ago to present to the Western Cape Department of Health on the Tenbison estimates for the Western Cape. And at that time, I was presenting the results of Tenbison version 4.2. And I wanted to show you here how the results have changed when comparing version 4.2 against the most recent versions, version 4.3 and 4.4. So the light blue bars here are from version 4.2 and the dark blue is from version 4.4. You can see that there's been an increase in our estimates of HIV prevalence. By the way, these are all indicators for 2018, so we're standardizing to the same metric. Over the same period, our treatment coverage estimates have dropped. Also important to note here is that back in version 4.2, our estimates had very wide confidence intervals around them. And I think when I last presented to the Western Cape Department of Health, I was quite frustrated and worried about the wide ranges of uncertainty around the Western Cape estimates, you can see that in the more recent versions, we've managed to reduce this uncertainty quite substantially. Next slide. So why have the HIV estimates for the Western Cape changed so much when comparing the most recent version to the previous versions? Firstly, we've included new data sources in the calibration of the model. We've included antiretroviral metabolite data, proportions of patients who are male, and also, most importantly, we've included the recorded death data in the most recent version of the model. So all of these new data sources give us more statistical confidence and help to narrow the confidence intervals. Also important to note is that previously we assumed antenatal bias was constant over time. When we talk about antenatal bias, we're talking about the difference in HIV prevalence between pregnant women and HIV prevalence in the general population. Our recent work has shown that this antenatal bias is not constant over time, and so our more recent models have made provision for this, and this affects the trends in HIV prevalence over time. Also, the calibration approach has changed. Previously, the provincial models were calibrated separately to the ART data and the prevalence data, and this meant that it was possible to get the model to produce a good fit to the HIV prevalence data, even if that fit implied completely implausible levels of antiretroviral coverage. We've now integrated the process so that there's a single calibration process, and that prevents these awkward inconsistencies. And then finally, important to note is that the newer models allow for higher HIV prevalence in migrants into the Western Cape. Previously, we were implicitly assuming that the migrants into the province had the same HIV profile as the current population, which is particularly unrealistic for the Western Cape province. Next slide. So in this next part of the presentation, I'm just going to compare our results across provinces. Here we're looking at HIV prevalence in 2020 for the 15 to 49 age group. Consistent with previous surveys, we find that Western Cape is still the province with the lowest HIV prevalence. The prevalence is 11.8% compared to 19.5% nationally. Next slide. Unfortunately, though, we also have the lowest treatment coverage. So in 2020, we estimate the coverage to be 57%, which compares to 66% nationally. Next slide. This shows our model estimates of condom use and changes in condom use over time. In all provinces, we estimate that there was a substantial increase in condom use in the late 1990s, leveling off around 2005. And Western Cape in dark green and Northern Cape in yellow have consistently been the provinces with the lowest levels of condom use in South Africa. Next slide. Here we're looking at the proportion of men who are circumcised. You can see that in most provinces, there's been a substantial increase in the coverage of male circumcision over the last decade, but Western Cape in dark green is the one province in which we've seen very little increase in male circumcision coverage. Next slide. Here we're looking at HIV incidence trends. What we're seeing here is that in all provinces, there's been a steady decline in HIV incidence since the early 2000s. You can see that Western Cape in green has consistently had the lowest incidence, but also it's the province in which the incidence decline has been most gradual. Next slide. You can see that more clearly here where we're looking at the percentage reduction in HIV incidence between the start of 2010 and the start of 2020. Here you can see we estimate that reduction to be 28% in the Western Cape compared to 50% nationally, and less than half of what has been achieved in provinces like KZN, Free State, and in Mpumalanga. Next slide. I want to finish off by just talking a little bit about our plans to extend the Tenbison model, and a lot of this is work which is currently already in progress. We are currently extending the Tenbison model to include TB, and our hope is that by the end of this year, we will have national level estimates of TB indicators for the country as a whole. In the longer term, we will then extend Tenbisa, the TB component of Tenbisa to the provincial level and be able to produce TB estimates for each of the provinces as well. We're also busy analyzing changes in marriage rates over time and across provinces, which is important in terms of understanding behavioral dynamics. We are currently working on including self-testing and index testing into the model. We've also, we still need to do work on updating the demographic assumptions, particularly to reflect the COVID-19 impacts. We had hoped to include this in version 4.4, but unfortunately we just ran out of time. So this is a limitation of version 4.4. We also want to include key population survey data in the calibration of the provincial models. Currently, we use these key population survey data in calibrating the national version of the model, but not in the calibration of the provincial models. And this means that our key population estimates at a provincial level are very uncertain. And then finally, we are calibrating provincial models to HIV testing yield data. So previously, we've calibrated only to total numbers of tests at a provincial level, but we also need to incorporate data on what proportion of those tests are positive. Next slide. The Western Cape is in a very unique position in terms of its routine data. It's the only province which has a unique patient identifier, which allows us to link patients across health facilities, which means that there's a great richness in the data. And unfortunately, we haven't really made full use of this data in calibrating the provincial versions of the Tenbison model. We've just been calibrating to the model to the data that we have available in all provinces, but we would like to do more work in terms of incorporating the data that are specific to the Western Cape. We're particularly interested in data on trends in CD4 distributions at treatment initiation. We're also interested in trends in numbers of individuals who've been on ART but aren't currently on treatment. We have great difficulty in estimating rates of treatment interruption and duration of treatment interruptions, but these data would be very valuable to us in terms of reducing that uncertainty. And then Nisha's recent work on estimating rates of repeat testing after treatment initiation and rates of linkage to ART after diagnosis is also very valuable to us. Although it's only one clinic, if we could get a more representative sample of clinics from across the province, that would be really valuable for us in terms of improving our assumptions about diagnosis and treatment. Next slide. So to summarize, our confidence in the Tenbisa estimates for the Western Cape has improved a lot over the last 2 years as we've incorporated more data into the calibration process and as we've refined the model. Compared to earlier versions of Tenbisa, version 4.4 gives us higher estimates of HIV prevalence and lower estimates of treatment coverage. Based on this, it appears that Western Cape is performing relatively poorly compared to the other provinces in terms of its HIV prevention and treatment programs. And so it's not too surprising that it also performs relatively poorly in terms of reducing HIV incidents. Having said that, I should also mention that because the epidemic in the Western Cape started later than in the other provinces, we wouldn't expect HIV incidents to reduce as much as in the other provinces. So even if we were performing equally well on our prevention and treatment programs, we wouldn't expect the same proportionate incidence reduction in the Western Cape. Lastly, the province is in a very unique position in terms of its routine data, and there are many opportunities to incorporate these routine data into the calibration of the Tenbisa model. We look forward to working with the Phdc in the Western Cape to refine the Tenbisa model in future. Next slide. And that's pretty much all I wanted to say today. If you do want to find out more about the Tenbisa model, please do check out our website, tenbisa.org. Unfortunately, the Tenbisa version 4.4 estimates are not yet on the website, but I'm hoping that we will be able to post them up in the next week or two. So do please check the website when you get a chance. Last slide. And finally, I just want to thank everyone who's been involved in terms of contributing data to the Tenbisa model and giving critical inputs, and particularly want to thank UNAIDS for funding the Tenbisa model over the last 4 years. Thank you.
Thank you very much, Lee, for a fantastic presentation. It was really clearly presented. We have a little bit of time for questions. We've got about 5 minutes for questions of clarity, and then we will have broader discussion in the second hour of the session. So are there any questions? Please indicate with the raise hand function. I haven't seen anything pop in the chat as yet. So Lee, this seems to be that you presented so clearly that there are no questions of clarity.
I think there's a question from Linda Gale and from
there we go.
So, hi Nisha, hi Lee, sorry, and I had to come from another meeting. I was a little bit late, so I may have missed it. Forgive me if I did. Just, you spoke about sort of migrants or people coming into the province having a higher prevalence. I mean, do we have any sense of how big that is in terms of its impact on those higher HIV prevalence rates overall and lower ART coverage?
That's a good question. So we haven't actually looked at that. We assume that most of the migrants coming into Western Cape are from Eastern Cape. So we basically are using the HIV prevalence estimates from the other provinces to determine that profile. But it would be good to, as you suggest, run a kind of an alternative scenario where we look at what the epidemic in the Western Cape would have been like if we didn't have those migrants increasing HIV prevalence. So it's a good question, and it's certainly something we can look at, but we haven't looked at it yet.
Great, thank you, Lee. Linda Gale, did you have a follow-up to that? Okay, great. Marianne?
No, just thanking.
Okay, great, thanks. Go for it, Marianne.
Thanks very much, Lee, for an excellent presentation, as always. I don't know what we would do without Tenbison. I had a question quite early on. You showed a slide of how mortality decreased very steeply after the introduction of ART, but now has plateaued. And if one wanted to be pessimistic, there's almost a bit of an uptick in the number of deaths, although the confidence interval looks like it gets quite wide. So I had two questions. The one is, how does that take age into account? Because obviously our population with HIV is aging, and those people do have to die at some point, and may not be dying because of their HIV. And even if they are dying because of their HIV and a little bit younger than they would have, they may still be having quite good life expectancy. And the second question is, why does the confidence interval get wider at that point?
Okay, both good questions. So the reason why was, let me first answer the age question. What I presented was just the AIDS deaths, so deaths due to HIV. It's not all causes of mortality in people living with HIV. And so it's not that they're dying from other causes, they are dying as a result of HIV-related issues. We do in the model assume that there's an increasing rate of HIV-related mortality in older adults. And this is what we've found in previous analyses of the IDEA data. So some of what we are seeing is indeed an aging effect, but it is all HIV-related mortality. Your second question was, sorry, it's gone out of my mind.
The confidence interval got wide, and I wasn't sure why that was.
Yeah, it's a fairly common phenomenon when we project out. We have less recent data, and so it always, the confidence intervals tend to get more uncertain in the more recent periods. But I think also important to note here is that we were calibrating to mortality data up to 2016. Stats SA haven't yet released the more recent death data. And so part of the reason why those confidence intervals get wider is that we've only been calibrating to mortality data up to 2016.
Thanks, that's great.
Are there any other questions? We can squeeze one more in if there are any questions. I don't see any raised. There, Karen, go for it, Karen.
Thanks very much. Thanks, Lee. I was just wondering, you reflected there that the Western Cape's got one of the lowest proportions of people on ART treatment. And I'm wondering if it's linked at all to one of the other statements you made, that we've got such good quality and multi sources of data. And I'm just wondering if somehow those two things are linked, that actually is it provinces where it's just not known that the people who perhaps started on art are no longer on art, whereas the Western Cape knows that they're no longer on art?
Thanks, Karen. So we've only been calibrating the model to the data sources that we have for all provinces. So I think what you're saying is that maybe we should trust the ART data more in the Western Cape than in the other provinces, which may be true. It's hard for me to make a call on that, but I guess it's not impossible that the ART data from TIA may be less reliable in the other provinces than it is in the Western Cape. Sorry, that's a very evasive response. I think the short answer is I don't know.
Yeah, thanks very much. I guess I'm just surprised. I would have imagined we were doing better with the art treatment program than how it reflects.
Sure.
Thanks, thanks very much, Lee and Karen. And I think these are some of the issues that we can delve into a bit more during the discussion time, because this is exactly the purpose of today's session, is to actually ask questions around these issues and really interrogate what the models tell us, what our routine data tells us, and so forth. I think in the interest of time, I'm going to hand over to our next speaker, who is Jeff Eaton. And Jeff is a senior lecturer in HIV epidemiology in the Department of Infectious Disease Epidemiology at Imperial College London, and an honorary associate professor in the Population Studies Group at London School of Hygiene and Tropical Medicine. Its research interests involve developing new mathematical models, statistical methods, and surveillance tools to characterize HIV epidemic trends, transmission dynamics, and the demographic impacts of HIV epidemics in sub-Saharan Africa. He co-chairs the UNAIDS reference group on estimates, modeling, and projections, and is a co-investigator of the Alpha network of general population HIV cohorts in sub-Saharan Africa. Jeff holds an MS in statistics from the University of Washington and PhD in epidemiology from Imperial College London. Thank you very much for joining us, Jeff. I'll hand over to you, and I can see your slides, so you can go for it.
Great, thanks very much, Nisha. And you know, one bit of Lee's biography that Nisha forgot to mention is that he made a very influential trip to Seattle about 15 years ago, where he told me what HIV modeling was, and so it's kind of especially humbling to get a chance to share a stage with him today to talk about HIV estimates in the Western Cape. The other preamble that I would give to the presentation here is I think one of the things that we've learned as we've started studying HIV at the district level more is that the details really matter, and those details become clear when you talk to people who know the details and know the data well. And so I think I'm really excited to have a chance to speak with you today and get feedback on this. And so I'd say, you know, be gentle, but don't be too gentle, because I think we really are eager for this as an opportunity to think through the way that we're interpreting the data, the assumptions that we're making, and what the opportunities are to use the wealth of data that are available in a better way. So first, acknowledgements. I just want to mention people who have kind of specifically supported with ideas and data and analysis that have gone into the current update of these NAOMI estimates. So Lee and Gesina, as well as the team from the National Department of Health, the HSRC, SANAC, and the US government partners involved. So an outline, I'll give a brief overview of the NAOMI approach and model. I'll talk about the NAOMI district HIV estimates at the national level, the most recent update in September of 2020. Then focus on some of the district estimates results for the Western Cape province, and summarize some of the future directions and possibly what some of the priority areas of uncertainty are in the model, and opportunities for more in-depth analysis in the Western Cape. So by way of background, I think everyone's, I'm sure, very familiar that there's an increasing focus on HIV programming targets and resource allocation at the district level. And annual targets are set for HIV testing and treatment based on district level estimates of unmet need. And I think attainment of these targets are increasingly being used as a metric of local program effectiveness and accountability for local governments and program implementers. To be able to do this effectively requires timely and accurate strategic information about the current status of the epidemic. And I suspect that we're also all very familiar of how inaccurate data can lead to inaccurate targets and disruptions to programming. But of course, the challenge that we have is that the data for quantifying HIV at the district level are much sparser than at the provincial or national level. In particular, in many cases, the household surveys that we rely on at national or provincial level aren't powered to provide precise estimates at the district level and such. So the objective for this project has been to develop robust district level estimates for multiple outcomes of interest that are needed for program planning. So prevalence and the number of people living with HIV, treatment coverage and unmet need for treatment, and the number of new infections. To produce these estimates stratified by sex and 5-year age group, and really with a focus on estimates the current time period and a short-term 9 months to 1 year projection ahead in the future for program planning purposes. And the approach that we've taken to doing this is an effort to bring together and synthesize and triangulate all of the available data sources that we have at district level simultaneously and cohesively. So the data that we use in South Africa and specifically include population data. We use district population estimates from Statistics South Africa, the mid-year population estimates from 2020, we've just updated to using. And these are adjusted to align to the provincial population estimates from Tenbisa and Tenbisa 4.4. We use household survey data about 3 outcomes: HIV prevalence, ART coverage, and recent HIV infection. For HIV prevalence, we use data from both the 2017 HSRC survey and the 2016 Demographic and Health Survey. And then for ART coverage and recent infection, we use data from the 2017 HSRC survey. We also use data about HIV prevalence and ART coverage prior to the first ANC visit from routine antenatal HIV testing. These are the data that are reported by facilities on a monthly basis to the national DHIS2. And then we use data about the number on treatment for children below age 15 and adults age 15 and above, reported to the national DHIS2 for public sector treatment program, and data on the number receiving treatment through the private sector from the Council for Medical Aid Schemes, who have recently started providing district level data on the number receiving treatment through medical aid schemes. So these data sources are integrated together in a Bayesian small area estimation statistical model. And the model jointly models HIV prevalence, treatment coverage, and incidence to get estimates, cohesive estimates for all of these outcomes at the same time. The development of the district estimates for South Africa, we produced the first version of district estimates in January of 2019. These were reviewed by the National HIV Estimates Technical Working Group in May of 2019. We updated these subsequently in January of 2020 and implemented the model in what we've now called the Naomi model. Those estimates were updated with HIV program data up to October 2019. Then in November of last year, we launched the website hivdata.org.za to host the district HIV estimates for South Africa and produce their estimates updated with program data to March 2020. And now what I'll speak about today are an update of the estimates from last month that updated the program data up to September of 2020. So the reference point for the data I'll talk about today will be September 2020. Just for a brief comparison of Tenbisa and Naomi, they use many of the same data sources, but are quite fundamentally different in their modeling approach. So Tenbisa is focused on estimation at the national and provincial level, whereas Naomi is focused on district level estimates. Tenbisa is a mathematical model that represents the full HIV transmission dynamics of the epidemic, whereas Naomi is more of a statistical model, a statistical small area estimation model. And Tenbisa reconstructs the entire HIV epidemic back from the start of the epidemic and is capable of producing projections for medium to long-term projections of the epidemic and intervention scenarios. Whereas for Naomi, we're really focused on granular estimates of the current epidemic situation for district level planning, but we don't represent the full history of the epidemic and aren't capable of producing credible medium to long-term projections because we don't model all of the intricacies of HIV transmission dynamics and the impact of interventions in the way that Tenbisa does. For model outputs, the model outputs several indicators. It outputs population, HIV prevalence, and the number of people living with HIV, treatment coverage, and the number of residents on ART in each district, the proportion and number who are aware of their HIV status, the number who access ART at health facilities in each district, what we observe through the program data, the HIV incidence rate and the number of new infections, and the predicted number of public sector ANC clients stratified by HIV and ART status prior to the first ANC visit. For each of these indicators, we produce a central estimate, a mean estimate, but also produce probabilistic uncertainty ranges. So it has including a standard error and a 95% uncertainty range for each indicator. And all of the indicators are produced at different stratifications that are useful for various planning purposes. So outputs are produced at all levels of the health planning hierarchy, so national, province, and district, produced for females and males separately or both sexes combined, produced by 5-year age groups, as well as more aggregated age groups that are often useful to represent data, and then produce estimates for 3 time points, June 2017, and then sorry, this should now be September of 2020, and a projection forward to September of 2021. I'm now going to speak very briefly, just on one slide here, about some of the kind of key concepts or components that we bring together in the model, and I'm happy to answer more questions about the methods later if that's useful. So the first concept is this concept of small area estimation, where we have relatively small samples from the household surveys within each district, but we use the HIV prevalence and ART coverage amongst pregnant women attending antenatal care to help predict the spatial pattern of HIV prevalence and treatment coverage across districts. So of course, the levels of prevalence and treatment coverage amongst pregnant women are different from the general population, but we can use that spatial pattern to help make our district estimates more precise. Secondly, we use this concept of joint estimation of HIV prevalence and ART coverage. So I think in previous small area estimation exercises, prevalence and the number of people living with HIV have been considered quite separate from the antiretroviral treatment coverage. But of course, we can imagine that knowing something about the number of people on treatments in a district tells us something about the number of people living with HIV in that district, in particular, if we have some additional data about ART coverage. So we consider that, fundamentally, we have 2 different sources of information about the number of people living with HIV in a district. We have HIV prevalence data from a survey, which we can multiply times a population size. But also we have our ART program data about the number on ART. And from our household surveys, we have data about ART coverage. And so we can take the ratio of those to give us a separate estimate of the number of people living with HIV, analogous to a service multiplier method for a key population size estimate. And then we can combine those 2 estimates together to get a more precise overall estimate of the number of people living with HIV. Thirdly, when trying to reconcile the available data about the number of people receiving ART at facilities in a district, trying to reconcile that with the population size, HIV prevalence, and treatment coverage data from surveys, we see that we need to account for some people receiving treatment at health facilities in different districts than the district of residence. So I think anecdotally, there's a great deal of evidence for this, that for convenience or perceptions about service quality, people may seek treatment in different locations than where they reside. For example, they may come into major metropolitan areas to access health services. And we incorporate this into the model by modeling a probability that people living with HIV in one district might attend a health facility in their home district of residence or a neighboring district. And fourthly, in order to estimate HIV incidence, we include a very basic epidemiological model for HIV incidence at the district level that essentially encodes the assumption that the spatial risk of HIV infection is proportional to the HIV viremia at the population level. So using the HIV prevalence and treatment coverage data that we've estimated in the previous model steps to inform what the expected incidence is in each district. And then we additionally incorporate the recent infection testing data from the household surveys using the Cascade et al. Estimator that's widely used to interpret the RETA data. And then lastly, we use outputs from the Tenbison model to project forward the HIV population from the most recent household survey in 2017 to the current time period. So we don't incorporate any specific district level data on HIV survival, but instead use provincial level estimates of HIV survival of the HIV population on treatment and not on treatment from Tenbison in order to project forward from the survey to the current period where we need estimates. So now I'll move on to some results from the model at the national level. This first figure here simply shows the estimated HIV prevalence amongst adults 15 to 49 years across districts nationally. HIV prevalence is, of course, the highest in districts in KwaZulu-Natal and in Mpumalanga province, and the lowest in the Northern Cape and the Western Cape districts. In terms of the number of people living with HIV by district, Johannesburg and eThekwini have the largest number of people living with HIV. You can see those estimates as well as the uncertainty ranges around those estimates. Cape Town, I believe, has the sixth highest number of people living with HIV across the districts of South Africa. In terms of treatment coverage, as Lee alluded to at the provincial level, or sort of at the provincial level, we see a similar gradient in the ART coverage across districts, with much higher or high ART coverage in the districts in KwaZulu-Natal, nearing the 80% that would be needed to reach the 90-90-90 targets, whereas in many of the districts in the Northern Cape and the Western Cape, ART coverage is around 60 to 65 or 60 to 75%. In terms of the number of adults on ART, unsurprisingly, this looks relatively similar to the ranking of the number of people living with HIV by district. Again, Cape Town having the sixth highest number of adults on ART. Now, for the HIV incidence rate amongst adults aged 15 to 49 by district, see that overall the pattern of HIV incidence or HIV incidence is higher or highest in those districts that have large numbers of or high HIV prevalence and thus higher HIV viremia. And you can see that overall we have much larger uncertainty about the number of new HIV infections by district than we had about the number of people living with HIV or the number on treatment. And Cape Town is estimated to have around the fifth largest number of new infections, around 10,000 per year, but you'll see quite a wide uncertainty range around that. And so to access the district estimates, if you're interested in getting more from these, we've the September 2020 estimates that I've just presented here are available at the URL draft.hivdata.org.za, and those will be updated to the main page soon. And if you want to access those estimates when you browse to that page, you'll see a link to download the full estimates in spreadsheet format. Now we'll download a zip file that has a spreadsheet containing all of the estimates at the national, provincial, and district level, stratified by sex and fine age group, with the estimates and uncertainty ranges. That zip file also contains a GeoJSON boundary file if you want to use those to produce your own maps, as well as other summary metadata about the data and model configurations that were used to produce the estimates. And now moving on to some estimates for the districts in the Western Cape province. Zooming in on the HIV prevalence in the Western Cape districts, we see the highest HIV prevalence estimated to be around 12% in Overberg and 11% in Garden Route. You'll see here that the uncertainty ranges around some of these estimates are quite large. For example, from 9% up to almost 16% in Overberg. Then in terms of the number of people living with HIV, I'm sure it's not a great surprise that this is the largest number is in Cape Town. And again, here you emphasize the relatively wide uncertainty ranges that we currently have around the estimates for the number of people living with HIV by district. And here we show the estimates for ART coverage by district in the Western Cape districts, between 60 and 65% in most districts, estimated to be slightly lower in West Coast district. Although again, noting that the range here is somewhat larger than what we saw, for example, in the provincial level estimates, around a 15 percentage point range in the ART coverage estimates for many districts. And then here in terms of the number of residents on ART by district, we have estimate here around 203,000 residents in Cape Town on treatment, 35,000 Cape Winelands, and smaller numbers in the other districts. And this plot, I'm going to show the comparison. I mentioned that one of the key features of the model, the key components of the model, was modeling this probability that persons might seek treatment in a different district than their district of residence. So what we have data about from the ART program data is the number of ART clients at facilities in each district. And then what we model as the numerator for ART coverage is what is the actual number of residents on ART divided by the number of people living with HIV. So this shows the comparison of those two estimates. And we see in the city of Cape Town, there's around 217,000 people receiving ART at health facilities in Cape Town between the private and the public sector. We estimate around 209,000 residents on ART in Cape Town. Whereas if we look, for example, at neighboring West Coast, we estimate there's only around 13,000 or 14,000 people receiving ART at facilities in West Coast, but around 19,000 residents on ART estimated to be on ART in West Coast. And I'll come back to some more results around this just a bit later. Then for HIV incidents, we again see here the estimates of HIV incidents per 1,000, highest in Overberg and the Garden Route provinces that had the highest prevalence. We also see a relatively higher estimate of incidents in West Coast, where the ART coverage was somewhat lower than the other districts. And in terms of the estimated number of new infections amongst adults, as I said before, estimated to be around 10,000 new infections in the city of Cape Town, but with quite a wide range from 6,300 to 15,000, and smaller numbers, but similarly wide uncertainty in the other districts. So the last thing I wanted to show here was some more detailed results about that component of the model, the estimation I mentioned of where people reside versus where they seek treatment. If you weren't suspicious before, this is where I hope you start paying attention with a bit more of a laser eye, because as I mentioned, it is really, there's no direct data about this going into the model. We found it very hard to find specific data about this. And so these estimates really come from a relatively crude triangulation of the data about the number of people receiving treatment compared to the population size, prevalence, and ART coverage. But what this first slide here is showing is amongst those who are receiving treatment at facilities in each district, where are they estimated to reside? So we see that amongst those who receive treatment in the city of Cape Town, we estimate that around 90% reside in the city of Cape Town, 5% in Cape Winelands, 3% in West Coast, and 2% in Overberg. You can see for those in who attend facilities in West Coast, we estimate that 87% reside in West Coast, 12% coming from city of Cape Town, but you can see the uncertainty around that becomes very large. It could really be anything down to about 0 up to quite a lot larger, simply because there's not much information there. And these show the same plot for the other districts in the province. We can now look at this kind of the other way around and say, amongst people living with HIV who are on ART in Cape Town, where do they attend facilities? Where do they, what districts do they go to for treatment? And the very large majority of people living with HIV who are on treatment in Cape Town get treatment in the city of Cape Town. If we go to the West Coast district, we estimate that around 30% of people on treatment in West Coast district are obtaining that treatment from facilities in Cape Town. Similarly for Cape Winelands, around 32% of people residing in Cape Winelands are obtaining their treatment at facilities in the city of Cape Town. And then similarly for the other districts here. So in terms of future directions, some of the things that we'd like to focus on, first is I think that the main thing that we all would like more precise estimates of are estimates of HIV incidence and what the trends in new infections are. And so as we noted before, that is the area that currently has the largest uncertainty around it. And so we'd like to think about how can we use the available data in a more precise way in order to improve the precision of those estimates. So think about how can we use triangulation of HIV diagnoses and ART initiations with ANC prevalence trends. And this is an area where the unique patient ID system in the Western Cape really provides an opportunity to do some pioneering work on this. Secondly, currently we've done estimates down to the district level, and we would like to continue to see if we can get down to the health sub-district level. Thirdly, to use more detailed sex and age stratified HIV program data. Currently, we very crudely used only data on the number of children and adults on treatment, which is all that's routinely reported to the national DHIS system. But I think we could get much more precise about this with more detailed data available. Fourthly, we'd like to continue to improve this modeling of ART attendance. As I said, it's a phenomenon that I think we all acknowledge or are aware from anecdotal evidence that it's happening, but we have very little direct data about it. And have consequently modeled it very crudely at the moment. But I think this is pretty important for understanding that relationship between population need and how our services are meeting that need. And so we'd really like some detailed interrogation of that and to think about how we can use data to improve how we model that. And then fifthly, starting to think more about HIV risk stratification and key populations at the district level, largely to help support targeting and coverage of HIV prevention services. So that's what I have, and I'm happy to take questions.
Fantastic. Thank you very much, Jeff, for a fantastic presentation that tied in really well to Lee's presentation. We have some time for questions of clarity. Do we have any questions? Please raise your hand with the raise hand function, or I haven't seen any questions in the chat as yet, but please feel free to pop in there as well. Okay, so it looks like there are no immediate questions, but perhaps we'll let it percolate a bit, and there may be some more questions and discussion items in the broader discussion. So thank you again, Jeff. Oh, there we go. Linda Gale, go for it.
Sorry, Nisha, brain works slowly. Just to ask you, Jeff, it's sort of apropos getting back to our migrant population who come in. I mean, presumably that's something you could have sort of time in a resident role or whatever. How could you factor that in?
Yeah, so that's exactly the type of data that we would like to incorporate. And so in particular, I suspect that the assumption that we've made right now that you get treatment in your home district or a neighboring district might not be very good actually for capturing these the dynamics of care seeking in South Africa, because a lot of the migration patterns are relatively longer scale migration patterns, and so we would really like to find data to quantify what those movements look like. And then I think the other question is where those people obtain treatment versus where they're counted as part of the population, I think is the key question to be able to address.
Fantastic, thanks, Jeff. Andrew, I see you have a question.
Yeah, thanks very much, Jeff. So going back some years, I used to have the kind of unenviable task of trying to help the province estimate numbers for the Global Fund, and it involved trying to take Lee's model for the province and disaggregate it by district. And we used to try to use a weighting by ART numbers or antenatal seroprevalence multiplied through population, or even HIV testing numbers. None of them worked perfectly, and they all gave slightly different results. From this small area Bayesian something that you do you have a sense of what's driving, what's the most dominant data source in driving which district patients are allocated to, or as dominant variables driving the numbers?
So I don't have a good answer to that, or a direct answer to that. But I do think that there's actually a very strong connection between those 4 different weighting schemes that you used before to what's come out here. In that, you know, essentially what we've done is actually just taken those 4 different approaches that were used before and combine them into a single model where they each come in. And you know, the approach, it would be an interesting analysis to look at more systematically. If we removed a piece of data, how much did it change the estimates? And so that might be a way to kind of answer that question more systematically. But also I think, like, at a conceptual level, what we've done here is I think a direct kind of further development of those different weighting schemes that were used.
Thanks.
Great, thanks very much, Jeff. I think we'll move on then to our third and final formal presentation for today, and that will be by Vanessa Timmerman. Vanessa is an epidemiologist and data analyst working at the Western Cape Provincial Health Data Centre. Vanessa has a microbiology background and completed her PhD in medicine at UCT. She also holds the Phdc honours degree in computer science. Vanessa has worked extensively in the area of health informatics and health system strengthening, with special interest in epidemiology and business intelligence. And today, Vanessa will be focusing on latest routine HIV treatment and care data. So over to you, Vanessa. We can see your screen, but it's showing me at the moment. So if you could just shift that to your PowerPoint slides. Vanessa, could you just unmute? Vanessa, you can just let me know if you want me to share your slides, if that will be easier. Vanessa, can you just confirm that you can hear me and that we can't hear you at the moment? If you could just say something. Okay, seems that we have some technical difficulty. Try one more time. Vanessa, can you say something? Okay, perhaps. Okay,
Yeah.
there we go. Andrew, did you want to say something? Go for it.
No, I do have a copy of Vanessa's slides, and I could try to channel her, or possibly, I don't know, Alexa, if you want to give it a go whilst Vanessa's sorting out her technical challenge.
Andrew, could you share the slides? I'm happy to talk through them.
Okay.
Andrew, perhaps you can just introduce Alexa briefly as well, just before Alexa starts.
Sure. So Alexa is the kind of the lead data analyst and architect at the Provincial Health Data Centre, who developed many of the HIV kind of evidences and Cascade prior to Vanessa joining the team. Yeah, and so many of the reports that we're drawing, etc., are things that that Alexa has stewarded over the last couple of years. And she is a bioinformaticist by training, but is very multi-skilled. And I see that it's up. Is that on who's?
That's me. I'll
yeah. Okay, perfect. And you have text. Your text is transcribing as well. So over to you, Alexa. Thank you.
All right, thanks, Nisha. You can go to the next slide. All right, so I'll start off by giving some background to the Phdc. I think a lot of people on the call are already familiar with us, but we are the Provincial Health Data Centre. We work as part of the Health Impact Assessment Unit in the Department of Health. And what we try and do is integrate data from all the different routine health information systems that are available in the province. So we call this data harmonization. And the reason we're able to do this is because of this unique health identifier that has been rolled out in the province over the past few decades. So there's just an example of a sticker that would be found on a folder, and lab reports and pharmacy scripts, etc. So some of the sources that we integrate include primary care systems, disease information systems such as TIA, which has been spoken about quite a lot. Our laboratory data comes from the National Health Laboratory Services, and that's one of our richest sources of HIV data. We get dispensing data from a few systems, including a chronic dispensing system and a system that's used primarily in hospitals, but also in most of the primary care sites. We get births and mortality data, primarily in hospital data as well. We get some information from community-based systems as well as emergency systems, and the hospital information system Clinicom, which is one of our biggest sources of data. And all of these data are accessible at a patient level, which is really helpful because it allows our data to be actionable. Nisha, can you change to the next slide, please? Thank you. So once we've got all of this data integrated, we try and present it in different ways to our to all of our stakeholders. The integration of the data, when we integrate it, we also enrich it. We try and infer health conditions. We look for inference of visits or facility touch points so that we can keep track of patient care. And we bring all of the inferences and cleaned up data into different views. So we have aggregated reports, which we display to managers. We have patient level line listings, which are typically very actionable reports, 1 line per patient, where you can see if they're lost to follow up or when their next visit is supposed to be. We have email alerts, which we send out to various stakeholders who've requested them, with lists of patients who meet their criteria. So one of the alerts that gets sent out every day is on anyone who should be eligible for genotype resistance testing, for people who've failed to reduce their viral load on their ART. We also have some administrative reports, and one of our biggest outputs is the single patient viewer. And the picture on the right is a illustration of the graphical viewer on single patient viewer. And what this does is it brings together all the different kinds of information that we have available for a single patient, in this case for their HIV episode, in a graphical view. And I'll just talk through it very briefly. So at the top, you'll see 2 bars, a red one and an orange one, and those are for 2 different episodes or health conditions that the patient has been inferred to have. And the big red bar is the HIV one, and when you click on that, the little sections below it all display. And the first one below it is the lab results. And here we have plotted viral loads and CD4 over time. The red dots are the CD4 counts and the blue dots are the viral load. And you'll see just below that is what we call the encounters or visits to facilities, marked by little blue lines for their primary healthcare visits. And just below that are bars of their ART dispensing over time. And you'll see that where there is a gap in treatment, the CD4 count of the patient starts to reduce and the viral load starts to increase. And at the very end of the chart, you'll see there was an intervention of a change in regimen. So this picture just illustrates how integrating all the data and displaying it in different ways, be it graphical or even in little line listings where all the data is available, can very quickly give clinicians or other individuals who are involved in following up on that patient a very quick view of their care over time. Thanks, Nisha. Can you change to the next slide, please? So this is to talk about the evidences that Andrew mentioned briefly. So what we do is we trawl through all the different kinds of data sources that we have and look for evidence of a health condition. So in many contexts internationally, people would probably rely on things like an ICD-10 code to infer that a person has a condition, or we might just rely on registers such as tier.net. But with all this data that we have, we can really get something a lot richer by bringing all the data together. So we divide the evidence that we have into a few different categories, and those are on the left. So I'll start from the top. We've got high confidence evidence, and these are things where if we were to see that evidence alone, it would be enough to indicate that the patient had that health condition. So for instance, if there was a detectable viral load test or a positive HIV test or a valid ART regimen dispensed, or an entry in a register like TIER, we should be able to say that that person has HIV. Then we have other evidence, which typically you would think that it would be enough to assume that the patient has that condition, but given our knowledge of the source system or how that evidence is reported in practice, we give it a lower confidence, so that you'd have to have multiple of those in order to yield a high confidence condition. And those, for instance, would be things like CD4 counts that were taken on the HIV panel of tests that were low value, or if we saw a viral load that was undetectable, We consider that as a weak to moderate evidence. Then we also have evidence that's supporting. So these evidences on their own wouldn't necessarily be enough to indicate that the patient has that condition, but when appended to the main episode, it would increase our confidence in that condition. So this could include things like ICD-10 codes, which we know in practice in hospital are prone to quite a lot of transcription error. Then we also get evidence which we call negating evidence. And these are things where, if we get a negative HIV test for an episode that we had only ascertained based on like an LDL viral load, for instance, we would then remove that episode because the negative HIV test after that undetectable viral load probably would supersede the previous evidence. So on the right, I've just got an example of how the evidences might look and how they get combined. So here's just an example of a few different evidences that the patient would have. So starting in 2020, early 2020, they may have had a rapid positive HIV test, and then later we saw that they were admitted and an ICD-10 code was given for HIV. And while they were in hospital, the labs were done and a detectable viral load was received on our end. And then they were dispensed a valid ART regimen. And a few months later in primary care, they got their second dose of ART and were entered into a treatment register. And we'd roll all of that information up into one line per patient, which we call their episode. And we store all the key information about that episode in that line. So the date of their first evidence or the start date, the date that we first saw their treatment, the last date that we had any evidence for that patient being in care, a list of all the evidence that we used to ascertain that episode, just so that we could go back and iterate by adjusting those evidences. And over the years, we've adjusted the evidences a lot, especially in the past few months since Vanessa's been on the team and has really been spending a lot of time dedicated to our HIV episode. And all those iterations try and help us build greater confidence in our ascertainment of the episodes. And then finally, once we've got that rolled up episode, we will combine it with other key indicators into what we call a cascade. And this will include all the different variables that might be useful for managing that patient's care. And this could include things like their last viral load dates and values, a treatment facility they might have been allocated to, ART regimens, other things that would be in the HIV cascade include things like their comorbidities, TB episodes or maternal episodes, etc. Shall we go to the next slide? Thanks. I just want to check if Vanessa's here.
Hello, can you hear me now?
Yes, we can hear
Yes,
you, Vanessa.
Can. Do you want to take over, Vanessa? Because this you've been working on.
Yeah, sure.
Great, thanks.
Okay, so what we're presenting here is the 1990 Cascade that we produce as part of the data center. So combining all the data and then producing this report. So basically, if we looked at, we've used Lee's model for the potential HIV positive people, and then from there we calculate the other numbers, the known HIV group. So we also are around 85.9%. And then we break it up also into people who are on ART. And for this, we look at people who've had ART quite recently in the past 3 months, the last ART in hand. And that brings us to about 63% at the moment. So it's quite spot on with what the models have picked up. And there you can also just see the numbers. The 309,000 is what's coming from us, from the Cascade. The 324,000 is model data. And then one of our reporting systems in the province is Njani, and that's also reporting in the order of 296,000. Then we also provide the viral load breakdowns, people with suppressed viral loads. So that's coming down to about 90%. And the net performance is just where we divide the number by the modeled HIV positive people, and not just by the people diagnosed in our center. So I've just highlighted there from the Tenbison model, females was in the order of 60% and males 50%. So that's also sort of in the middle where the 63 is coming from us, and Naomi reported 66% in their modeling. Next slide. This is a breakdown, provincial breakdown, district breakdown, sorry, where we also just listed the breakdowns and just showing, for instance, the metro compared to the Naomi model. So if we look at the number of people on ART, we estimated in the order of 209,000 in this cascade. And Naomi reported between 205,000 and 211,000. So it seems like the real world data is well aligned with the modeling as well. Next slide. This is just that lovely picture of Lee with the colors and how the trends have changed over time. So we've looked at the cascade and also broke the groups into those categories. So this is the Tenbison 4.4 model that we've used for this one. So we can see if we start at the bottom, on ART and virally suppressed are quite well aligned, 50% based on the cascade data currently versus the 53 for 2020 and 50% for 2019. Previous on ART and not suppressed, those are all between 3 and 5%, so also good alignment. Previously on ART, 16% from Tenbison model, we've got 18%, so slightly higher in that aspect. And then diagnosed never on ART, and undiagnosed, so this is the only categories where we slightly different in terms of our percentages, but it really depends on the settings and what time frame we use, and if should we include people who have died as part of diagnosis, etc. So it's literally what kind of parameters do we put into the undiagnosed group and the people we include for those. Next slide, please. Yeah, so this is the end of our talk. This is a slide just of the data center and the epidemiologists on board. So it's really a big team effort to get the data to this point where one can start to draw the reports and present. And like Alexa explained, so a lot of effort goes into combining the data and really getting it to a state where you can deduplicate and have quite an accurate sense of the data, what's going on. And what we can see also currently, about 92% of all the patients in the database got just one ID. So there's definitely about 8% of people with more than one ID. And I was thinking about the comment of Lee also earlier that the Western Cape's ART percentages is a bit lower compared to the rest of the province. So my feeling is also that there might be a slight overestimation due to the duplication of data that might be happening if systems are not centralized or linked to a centralized database. That's all from me then. Thanks, Nisha.
Fantastic. Thank you very much, Vanessa, for that great presentation, and many thanks and congratulations to Alexa for stepping in without hesitation. That was fantastic. So thank you both, and to the entire data center team for all the work that goes behind the scenes. Are there any questions of clarity for Alexa and Vanessa? If not, I think this really, oh, Jeff, go for it, Jeff.
What was the distinction between the Sinjani data for number on ART and the TROA number that you showed?
Vanessa, were you able to get that?
Yes, I'm just quickly going to that slide. Sinjani at 296,000. We reported 309,000, so about a 15,000 difference.
What's the Sinjani mean there? What's that data system?
I think Andrew and Jonathan can probably speak a bit more to it, or Alexa even. As far as I understand, it's more aggregated data that's imported into the Sinjani system for DOH reporting.
It's DHIS effectively.
Why is your number that's really interesting that it's higher, because we've wondered if the DHIS numbers were too low frequently, and so I'm curious, do you know why it's higher?
I'm not too sure, but maybe any of the other colleagues. I think, Alexa, do you have an idea why we do differ so much?
Well, one of the reasons could be that so the Sinjani data comes primarily from the primary health care information system. So it's an aggregate of what's in our PHCIS and premise systems. And we also augment that with laboratory information data and drug dispensing data, which could cause a few differences. It could also be the way that we're determining who is active in the province in that period of time. Andrew, any other suggestions as to why ours might be slightly higher?
Yeah, I think there are some sites that are not reporting sites where diagnoses are made, etc., where they would ultimately make it into the primary care system, but we might pick it up sooner. And also, that's not a massive difference, I don't think. I actually think it's quite close. Given how much uncertainty there is with these numbers.
Fantastic. Thanks for taking that question. So I think this gives us a good lead to our broader discussion. So I'd like to welcome Andrew Bull, who I think everybody knows at this point of this session, who's going to chair the discussion. And Andrew's a renowned public health medicine specialist with the Western Cape Provincial Department of Health and professor of public health medicine at the University of Cape Town, and currently provides oversight for the Provincial Health Data Centre, and has a long-standing involvement in routine HIV data. So Andrew, I'll hand over to you, and I will also keep an eye on the chat for any questions or discussion points that come up there. So over to you, Andrew.
Great, thanks so much, Nisha, and huge thanks to the presenters. Even as somebody who kind of works in government and quite close to the data, I don't think we've, for quite a long time, and especially with the disruptions of COVID, I don't think we've sat down and taken stock of where we are in the epidemic. So it's very timely to have the contributions of two very recent calibrations of models to the Western Cape data, and for some sober-minded reflection on where we're at. And maybe just to summarize, I think from Lee, we've got an update of where we are. We've got an estimate of more people living with HIV in the province, and probably for those of us who've spent so long working in HIV services, quite a devastating reflection on performance. And maybe some of the discussion can look at that. I think from Jeff, I think you've solved a problem for us. We now know where to get those district numbers for next time that we need them, and we'll certainly be incorporating them as the denominators into all of our reporting. So we're very excited to have a model that's giving us district level estimates. And I think from the PHDC, it's very reassuring that the numbers align, and underlying those aggregates that Vanessa showed is the potential to drill down and actually find the individuals underneath each of those numbers, and some of them that we can hopefully reach to re-engage in care or to improve their care. So with that summary, can I ask if there's anyone who wants to kick off with commentary or questions to the presenters or to the group? And I see Brian Rice. If I can just ask each person to also just introduce themselves as well at the start of their question. Thank you.
Thanks, Andrew. Yes, so Brian Rice. I'm Deputy Director of the MeSH Consultant and Associate Professor at the London School of Hygiene and Tropical Medicine. First of all, I'd just like to say, fantastic session, really interested, 3 great presentations. And as somebody who flaps, I need to learn from you as a group how you deal so calmly when you have technical issues like you just faced. I thought that was a masterclass. Just a few pointers to pick up, actually. I find myself at the moment, for my sins, with my head thinking a bit more about the use of ART metabolite data and CD4 cell counts in our surveillance response, particularly around the use of strategic information. And I wondered if Lee could say a little bit more about how he's incorporating those 2 streams of information in his models. And I did have a bit of connectivity issue while Jeff was presenting, but I thought that he presented prevalence estimates amongst adults by province that were considerably different to what Lee had just presented. I might have picked that up wrong. If I'm right, it'd be nice to hear from Lee and Jeff as to why there may be variation between the Tenbison and Naomi model with that. Thank you.
Great. Shall we? Those are very specific questions, so maybe we can go back to Lee and then Jeff.
Sure. So thanks, Brian, for that question, or questions, I should say. So to answer your first question about how we incorporate the metabolite data, we compare our model estimates of treatment coverage with the survey data estimates of the proportion of people living with HIV who have detectable ARV metabolites. So that's a kind of an additional data source that we use in calibration that we didn't previously use. We don't currently use routine CD4 data in calibrating the model. This is something we would like to include in the calibration process. And in fact, Western Cape Department of Health has previously shared this information with us. We're particularly interested in CD4 count at treatment, although this has obviously become a lot less reliable in recent years with baseline CD4 count testing not being done as frequently. But it is nevertheless something that we would like to include in the calibration. Your second question about differences between Naomi and Tenbisa. So the 2 models, as Jeff described, are quite different in terms of their approach and their structure. They are calibrated to different data sources, and so we wouldn't necessarily expect them to produce the same results. But you are correct that the Tenbisa estimates are a bit higher in terms of HIV prevalence and a bit lower in terms of treatment coverage than Naomi. We're never going to get the models exactly consistent, but we do need to try to understand why these differences exist. And it's an ongoing area of discussion between Jeff and myself. So Jeff, I don't know if there's anything you want to add on that question.
I was going to chalk it up to Brian's connection issues, but you've given a much better answer. I did actually, to comment on the ARV metabolite question, that was, I think, one of the exciting developments in both the Naomi and Tenbisa models was to incorporate those data more formally. That is my excitement about seeing that comparison of the Western Cape data system with the Sinjari data system. One of the things that motivated that is when the HSRC survey was released, the 2017 survey, the ARV metabolite data from that survey implied a quite substantially higher number on ART in South Africa than what the ART program data were in South Africa. And so there's myriad reasons why that could be, and what both of the models do is try to balance the ART program data with that survey data. But also one of the questions we asked when that happened was, are there reasons that the program data from DHIS2 could be underreported? And so Vanessa's presentation was one of the first quantitative kind of suggestions of that I've seen. And so that was why that was such an interesting comparison.
Can I just clarify as well, Jeff, the denominator for your coverage estimate? So it Tenbisa is very clearly the model number of people with HIV, not just those that are known. How do you get to the denominator?
Yeah, so that's the same. It's the estimated total number of people living with HIV, which is based on the survey prevalence data, population data, as well as the number on treatment and the survey coverage data, all weighted together.
Okay, so it's the same measure, just different findings. Thanks.
Yeah,
okay, so, thanks very much. So to move on to Linda Gale.
Thanks, Andrew. And similarly, I just really thank 3 great presentations. I think that was just really very interesting. And I fall into your category of feeling quite dismayed, Andrew, I must say, although I am tempted to go with Corin's optimistic viewpoint that we're not so bad because we actually collect good data, doesn't, deflect from the fact that we don't look great at all. And even if you take the other 8 provinces away, we still don't look great in terms of that second 90. So I do think this is timely reflection. And some of the thoughts that are going through my mind at this point is it would be nice to see how we look over time. I'm going to be a bit provocative. I know it's a couple of years ago when we sort of did away with our vertical HIV kind of programming, certainly in the public sector, and this doesn't apply so much to the private sector, but to the public sector, where I think the large majority of our HIV treatment program sits. And I wonder if the loss of focus is what has contributed to this. I'd like to see, have we seen a step down over time? Because I think that might speak to how our public sector emphasizes the HIV epidemic. Where I sit, I'm very concerned generally in the region that there's been a loss of focus on the HIV problem as a whole, not only in the COVID era, but predating the COVID era, because I think also we've lost focus on the elimination of mother to child and a whole lot of other things. So I think absolutely timely to do this, because maybe we need to walk some of those decisions back. As much as integration and UHC is important, I think if we lose ground on the HIV epidemic in a country where most of our health challenges sit in that epidemic, then we aren't going to realize UHC terribly soon. So I think this, it's somehow we need to get this going on a big scale. I do want to say that I'm very encouraged by this district level, because one of the things I've tried to stand on a soapbox for a really long time is that particularly in our province, because there is this dilutional factor, we keep having this 10 to 11% prevalence, which takes everybody's focus off this province. And yet when you drill down in particular districts, of course, there is a nightmare. And where I sit, from the placebo arm of the clinical trials that we run, we see high levels of incidence, particularly when we go into those districts where there's that are very informal. So I don't know how much of that, Lee and Jeff, are the migrant folk. I don't want to put all the the eggs in the basket of the Eastern Cape people who come into this province, but it does seem to me that those are the areas where we still see ongoing transmission. And I don't know if that's lack of service or just disruption in people's lives, or whether it is because they are newly arrived in our province. But I think again it really helps us focus where we need to put our efforts and take our services to. So I would just say those 2 major points, and welcome this, and I hope we do it frequently to ensure that we start to bend that green line down, Lee, because I think that's really troublesome. Thank you.
Good. Thanks, Linda Gale. So I wonder if anybody else, just to follow this theme a little bit, wants to comment on the performance issues, whether how they respond to this, and just to mention that prior to, this has been in evolution for a while, but when the 2017 HSRC survey was released, the Northern Cape and the Western Cape were also at that point admittedly with some concern about sampling and response rates, the lowest in the country in terms of proportion of the population that were virologically suppressed.
Andrew, if I can just respond to Linda Gale's first point. I didn't show it in my slides, but yes, we can look at how performance across provinces has changed over time. And definitely there was a period in the early 2000s and even towards 2010 when Western Cape had the best HIV program in the country. We had the highest rates of treatment coverage and mother-to-child transmission rates were lowest in the province. But unfortunately, that ranking relative to the other provinces hasn't been sustained. So we've seen that the other provinces have caught up, I should say, and exceeded us on a number of metrics. Thanks.
There's quite a few long-standing HIV program people on the call. I'm just wondering, any of them, Nellis, Karen, Ashraf, etc. If any of you want to comment?
Hi, Andrew, Ashraf here. Hi, everybody. No, I tend to agree with Linda Gale that we have seen the dilution effect. People have lost focus. And also there's been an unreasonable reliance on donor funding to come and fill the cracks and the gaps left through the shortage of staff and stuff. And that has really left people floundering. And, so there are lots of systemic issues which kind of impact on our focus. And maybe we need to relook at the vertical programs again, because certainly the integration is really critical and we need to go that way, but we have lost focus. And certainly COVID has not helped, especially getting access to medication. Multi-month dispensing has been, or the differentiated models of care with adherence support has really been limited in this province. People have been incredibly conservative and not brave enough to use the multi-month dispensing that has shown to be really useful in other parts of the world, especially in Zimbabwe and in some parts of the DRC. So, I just don't think we have been creative enough to deal with the ongoing challenges that we face on a daily basis, in dealing with the growing numbers, the in-migration, and the movement of people across borders. Thanks.
Thanks very much, Ashraf. I'm also, is anyone else wanting to come in?
Yes, Niels here, Niels from ANOVA. I just think that we're also struggling with understanding and to find the balance between case finding and retention in care. And if we're actually doing enough to try to get those, 18%, Vanessa, that's out of care or that's been in care, trying to get them back into care. I know we talk a lot of welcome back and we do that things, but how do we actually do that? And do we do it with, if we really did that paradigm shift that we need to take things and bring people back? I also want to ask is, with the Provincial Data Center, we can actually now make more use of that data, knowing the individuals, but I think there's still things about how do we really use that data and how do we connect people back to facilities? Maybe my question is, where do we go from here? How do we improve the Western Cape? Is it on case finding, retention in care? Which 90 do we need to work more? And how good are we allocating resources? Thanks.
Thanks very much, Nellis. So I think I can answer your second last question, which is about the which 90. I think the second 90 very clearly is the one where our performance is very clearly behind. Marianne, are you commenting on performance?
I was just going to comment on perhaps a response to Linda Gale and to the discussion around performance over time and comparison between our province and other provinces. I mean, I think in the Western Cape, where we have perhaps more in the way of other conditions, and HIV prevalence is a little bit lower, and HIV isn't necessarily always seen as our main problem, that this issue of not having vertical problems, it does make it challenging. And the other thing which I was interested in, I'm sure Tenbisa produces this data, but how does the age distribution of people with HIV, adults with HIV, differ in the different provinces? Well, Jeff would have this data as well, so I could go onto his website and look, but I haven't looked. And how does the comorbidity burden, other than HIV, differ in those people? And whether that adds to the challenge. So if you've got more people who have HIV but are also diabetic and hypertensive, you know, keeping them in care for all three of those conditions within a vertical program would be incredibly challenging in 3 vertical programs, and is clearly not the way to go, but that it might be, at the same time, by trying to do that, you do lose focus on just getting the HIV under control.
Yeah, thanks, Marianne. And I think that the coming off a low base, the trajectory of improvement will always be slower. Coming off, you know, where the provinces that had much higher morbidity and mortality obviously had much more room for rapid improvement. So I just wanted to also interrogate the notion that a lack of a unique identifier or data issues would be contributing to the modeled, the calibrations that result in these model differences. And I see, Meg, you posted in the chat. Is it worth just commenting briefly, besides the differential between the aggregate and the data center data, as to whether people could be counted twice with the routine reporting system, the aggregate reporting system? I don't know, Meg, if you heard that, or if somebody else.
Sorry, Andrew, I'm really struggling with connection issues, so it's breaking up a bit. Could you repeat that?
So the question was whether the lack of a unique identifier or perfect unique identifier would result in double counting in other provinces, because I think there is that assertion that maybe other provinces have overcounted their ART remaining in care, but I think that might not be the case.
Yeah, I mean, the way that the algorithms for aggregating the data are done, we shouldn't be double counting. So once a person leaves one facility and joins another, if they're out of medication for 3 months or longer, they'll no longer be counted in that facility, regardless if they've been provided or recorded an outcome against them. So we really shouldn't have a large number of people that are being double counted unless it's during that short window time. Yeah. So with loss to follow-ups, et cetera, if someone's lost to follow-up, they will be counted as a loss to follow-up once there's 3 months or more with drugs without drugs in hand. They'll transfer to another site, and then if they do show up at another site, they'll be counted at that facility and no longer at the original one. Does that answer the question?
Yeah, I think so. So that would also be my understanding that it's unlikely to be overestimation elsewhere as an explanation for the provincial differences in ART numbers and coverage. Jeff?
I was just going to add to that, the other data that we've been looking at to triangulate that, interprovincial or inter-district variation in coverage, is the treatment coverage amongst pregnant women prior to their first ANC visit. So that's routinely reported, and that shows very much corroborates that pattern of lower coverage in the Western Cape and the Northern Cape, and higher coverage in KwaZulu-Natal and Mpumalanga. you know, we were also very surprised at the results of the HSRC survey initially, but I think seeing both of those data sources telling that same story, you know, made us believe that it was probably accurate.
Good. Thanks very much, Jeff. So we've got just over 10 minutes to go. Are there any other general comments based on the presentation so far, or questions? That being the case, I wanted to just sound people out about this seminar series. So we thought it would be useful to have a space to kind of try and bring together data to reflect epidemiologically on the provincial epidemic. And we had planned to do this maybe quarterly this year. And it was kind of self-describing to start with, the kind of where are we in the epidemic. But in terms of future topics that people would like to spend some time getting inputs and thinking about, are there any specific suggestions or requests? Yeah, it could be in the line of kind of behavioral prevention, PMTCT, long-acting regimens. Well, not that we have them yet, but kind of potentials for innovative program changes. Although that might be more programmatic than kind of epi and data-based. Yeah, so I see, Linda Gale, you've got a suggestion, perhaps?
Yes, ever the activist, Andrew. So yeah, apologies for that. But what I wanted to, two things I wanted to say. The one is just that I think we need to not only continue this, I think this is fantastic and I'd love to be counted in, but I think we need to publicize it. So one of the problems is to bring donor money and other money to this part of the province, because, or this part of the country, because it's perceived to be done and dusted, you know, we're all cool and all fine. I mean, the number of conversations I had with the US attaché on this was just innumerable. And so I do think trying to find a way, although it isn't maybe, you know, very woke to go out there and say we're not doing very well, I do think we need to somehow, you know, request support in terms of trying to get this right. So that would be one piece. I don't know how to do it politically in the correct way, but I think we do need to get it out there. The second point I wanted to make is that there is a small group of us who've been really worried about the sort of backsliding in the eradication of mother to child. And so I would love us to start in the Western Cape to think about this. So if there is, and I'm sure Marianne is interested in this as well, but Chip Lyon and myself are trying to put together a sort of plan till 2025 to refocus people on an age-free generation and trying to get vertical transmission, you know, moving in the right direction, because we really think there's been loss of ground there. And so again, I'd love if we could start a focus in the Western Cape maybe, and then South Africa, and then the idea is to move beyond that into the region. And rather than have a campaign coming out of Geneva, as is often the case, to actually have an African-driven, you know, promotion of this, to say this is something that is relevant to Africa and we have to solve it in Africa. And so I would just, you know, see maybe this kernel starting from here to see what we can do in this particular area, which seems to me as a milestone we can reach relatively easily if we all put our minds to it. Thanks.
Okay, thank you. So I'm going to take that, Linda Gale, as an endorsement of vertical transmission as a next focus area. Anyone with further suggestions or want to jump the queue with a different topic? So I think that's good. I think unless in the interim somebody comes up with an urgent alternative, I think it is a logical next topic, and we'll get planning with something similar. Maybe a few more diverse shorter inputs we may ask the modelers to also just update us what their vertical transmission estimates are. Yeah, and with that, I think I just want to thank everyone and hand back. I see there's a hand. James, yes. Before I hand back to Nisha.
So Andrew, thanks Andrew, and thanks everyone for the meeting. I very much feel like I'm James Hargreaves. I'm also from LSHTM and oversees the MeSH consortium, so I'm very much a guest here. But just fantastic meeting, fantastic illustration of kind of using data. And so the one thing I was going to say is as well as looking for new topics, I think a real strength of a forum like this would just be continuity. And so I was going to drop you guys an email afterwards, but I thought I'd just say it now. You know, I think there's a couple of ideas for sort of further drilling down of data that have come up already in relation to some of the things that have been seen, and just, you know, just think one strand for a rolling meeting like this would be to, you know, to take those next delves down and keep some continuity on topics. So some ideas about delving down into sex and age distribution and those kind of things. So that was the point I wanted to make, but and to thank you.
Thanks, James. So possibly we could even have a 20-minute session at the beginning of each seminar where we just give feedback on further deep dives that have emanated from the previous one or previous ones. Yeah, just to keep that continuity going. That's great. Thanks. So Nisha, back to you. Thank you very much.
Thank you very much, Andrew. And thank you everyone for engaging, asking pertinent questions and contributing to the discussion. I'd just like to again thank our presenters, Lee, Jeff, Vanessa, and Alexa for their excellent, insightful presentations. We plan to have the next meeting in the series in June. We will send a calendar invite once the program and speakers are confirmed. And thank you for the suggestions today. And do let us know if you have any further suggestions for topics and speakers going forward, because we do want these meetings to be guided by you. And we look forward to meeting up again, having fruitful, robust discussions. So thank you all for availing yourself on a Friday afternoon, and have a wonderful weekend.
Thank
Bye.
you. Thank you, Nisha. Thank you, everyone. It's fantastic. Thank you.
Thank
Everyone.
you. Bye.
Thank
Bye.
you.
Thank you. Bye-bye.
Thanks. Bye.